Thank you for inviting me to this increasingly prestigious meeting, I would say. Now, there are many issues arising in the context of screening, quite different from much of the therapeutic business we're discussing at this meeting. We need to decide who to screen, how to do it, and more importantly, how to optimize our screening when we decide to do it, including the role of colonoscopy, and I'll come back to that. And also, which I will not deal with today, but which I think will become an increasing issue as well, is how to deal with all the surveillance, because all the screening creates a growing surveillance population, which in the end might create even bigger problems than the screening itself. Now, colorectal cancer, as you know, is a big problem already, and it will increase. Maybe not so much in the Western world, but it will increase in other parts of the world, so the global load of this burden is likely to increase substantially during the next 10 or 20 years. And in the context of screening, the WHO has set up some prerequisite for screening to be meaningful. It has to be a common disease, of course, with precursor lesions that you can detect and treat in a useful way. You need to have screening tools available, and you need evidence from randomized controlled trials as to the effects of the screening program, and I'll come back to some of those. Because I think based on this adenocarcinoma sequence that I will not go into detail on, this is exactly the situation where screening for detection of the left side early lesions does make a difference. And so these are the main screening options if you decide to go for screening. Fecal blood test studies, DNA panels of the stool, CT colography and flexible sigmoidoscopy, as well as colonoscopy. So these are all potentially available options in addition to colon capsule, which is not on this slide. Now, there's a difference between prevention of lesions versus early detection, and so some of these methods are not capable of detecting these precursor lesions. So particularly the fecal blood testing, as you can appreciate, it will allow early detection of cancer, but it will not allow us to detect non-bleeding polyps and remove them in a non-cancer stage, as opposed to the structural tests, primarily endoscopy and radiology, where you can also detect the precursor lesions and possibly remove them. And then you will also have an effect of incidence, at least potentially so. There are a number of screenings initiatives already in place in Europe in a systematic way, so a number of countries have already taken up this on a national level, as you can see. And even in some countries, primary colonoscopy for screening has been introduced. The problem of that is that although it does make sense, the actual benefit of colonoscopy in this context has not been shown in randomized controlled trials. And so fortunately there are initiatives going on right now, which is a very good thing, because I think very soon it would be ethically or politically very difficult to justify a randomized study, but we can still do that. And so these are three randomized initiatives, including this Nordic trial comprising 5 European countries, and I'll just to mention this study with 68,000 individuals randomized, although 45 of those are randomized just as a control group and will just be followed, but a screening group of 23,000 individuals, and actually the inclusion phase is over, so now there will be a 10 years or 15 years follow-up before we can really say whether screening colonoscopy as a primary tool does make a difference. So it's interesting that the method has been introduced in several countries already, despite the lack of these studies. Now, the role of colonoscopy in screening is either, like I said, to have it as a primary tool or to use after some of the other modalities show a positive findings. And also, it has obviously the role of surveilling those who have lesions which need a follow-up scheme. So colonoscopy comes into play in this either way. And quality in colonoscopy obviously is an important thing, but I think in the screening context, it's even more important than ever. Partially because a successful screening program requires decent acceptance in the population and uptake, and so patients, we need to attract the patients to this, which calls for extra quality. We need to detect early lesions, which is different from looking for symptomatic lesions, bleedings, or cancers, which means we have to be even better at finding small things. And I think the acceptance of risk and complications is less in the context of screening than we are used to accept in a clinical context. So all of these factors add to the requirement for quality in this context. There are a number of quality parameters which have been developed. I will not go into detail on that, but obviously those can be focused on the center level. It can be endoscopist focused or patient oriented, for example, pain score or patient satisfaction of the program. The different societies try to come up with quality indicators to be able to measure the quality of what we're doing. And this is just a table from a recent review which shows some of the issues not yet solved in terms of those quality indicators. So again, I will not go into that, just to show you that even though we have lists of indicators now, some of those are really not too well validated, and we need more data on that, which leads me to a small commercial for this initiative of the ESGE, the Quality Improvement Committee led by Matt Rutter from the UK, where we try to develop further the understanding of these quality indicators and how best to utilize those. And obviously this program relies a lot on what's already being done in the UK. Now for polyp detection, there are a number of issues there as well. It's presently suboptimal, although we think we're getting better. The miss rate is still in this range. It's not really decreasing over time, at least not as much as we would like. And it's depending on a number of factors, of which maybe these are the most important ones, at least some of the important ones. If you look at this video, which is not so long, I had this as a gift from my friend Michael Kaminski in Poland. But if you look at that, how many saw a polyp? And how many saw more than one polyp as well? I think this is the same region. You see that small polyp there, which is not so difficult to see. But I think this type of examples of how easily flat lesions can be missed, I think is quite interesting. Now there was a couple of diverticula there as well, which we also didn't see in the first pass, but as you go slowly backwards, you will realize there is a flat lesion, which is sort of more easily visualized, of course, with this catheter. But first you have to detect it, and as you can tell, I'm not sure about the histology of this, but it's certainly a significant lesion, and these lesions, we're still missing them. So just a word about bowel cleansing, because it's a lot of talk about technology and improving optics, etc. But really bowel cleansing is a prerequisite for all of that. So it's been shown that with poor bowel cleansing, the adenoma detection rate goes down, and typically the endoscopist is not totally happy, and he will reduce the screening interval, so it has direct effects on the screening program as well. And there are many unresolved issues in terms of how to standardize the assessment of cleansing, how to make a clinically relevant cutoff for when you see enough and when you need to shorten your intervals. And although there are a number of scales used for grading of cleansing, it has not been well translated into clinical use, at least not yet. And then technology, there are a number of technologies opting at improving our detection rate. One is high definition resolution endoscopes, as you can tell, with or without magnification. This allows us to see more detail, and now we're getting used to the HD resolution, And I think this is not the end of it. We see 4K TVs now, and this is a recent article about 8K imaging for medical purposes, and for sure the development of resolution will only go even more rapid, driven by other adjoining technologies like TV technology. So that will increase. Now, spray chromoscopy or digital chromoscopy has been shown in some studies to increase the detection rate, but at least for the digital versions, a little bit disappointingly low numbers, at least with the first generation of those technologies. This might improve, but so far it's mostly useful for characterization, delineation of lesions, not so much for detection. Third eye endoscopy is a way of looking behind the folds. It has shown interesting data, but in very small studies, and it's slightly cumbersome and has not really taken off on a larger scale. And what we see now is a number of implementations of widening the field of imaging, which also obviously would allow you to see more behind the folds, see a larger area of the overall area of mucosa. It will be interesting to see data on detection rates. So far, we have not so much. And finally, cap technologies with a clear cap or with these caps, which potentially allow us again to fold back the folds to see more. All of these technologies have individually been shown to increase detection rates in smaller studies. None of them have so far taken off as changing our situation. I think they're all additional benefits which together probably do make a difference. But I would like to finish this talk by commenting a little bit on the third factor I mentioned, the quality of the endoscopist. Because typically training in colonoscopy is much focused on intubation techniques, pain-free colonoscopy, and various therapeutic interventions. And now, increasingly also, we are trained to be better in characterizing surface of lesions. But detection competence, which is about the adenoma detection rate, may be trainable as well, but maybe we have not been focusing enough. This is just a small study from Mike Wallace in Florida, showing that even a very small intervention on his faculty with 2 one-hour lectures, really nothing special at all. Maybe it was just about focusing on the issue. They did this in a randomized fashion and looked at the 4 months after this very small intervention, and were able to show a quite substantial improvement in adenoma detection rate. And if you compare these numbers with what is shown with all the technologies coming to the market, I think it's very interesting to see how much you can really gain from even this type of simple low-tech intervention. And this is a small study, but there are newer data now coming from Poland, where they've done a lot of research connected to their screening program. And recently, this is data in press from the Center of Michael Kaminski and his colleagues, where they found 40 centers where the leader of the center had a documented adenoma detection rate of less than 25%. And these 40 centers, or these leaders, were randomized to a 2-day hands-on training program or just the normal feedback on their performance. And so with quite huge numbers, they were able to show that this intervention did have an effect on the adenoma detection rate, on the rate of proximal lesions, and on the rate of flat lesions. And this was the performance of the leaders of the centers, but actually they were able to show that even the center surrounding those leaders improved as well. So I think there is a lot to be gained from the training aspect as well, and we should not forget that in the context of all the technologies. So to conclude, quality in colonoscopy is obviously an important thing, but I think the screening situation makes it even more crucial to focus on this. And measuring quality, as I tried to explain, it's vital, but it's not so easy, and many of the indicators may not at present be optimal. Technology advances are continuously improving our possibilities, but they cannot replace proper bowel cleansing, and they cannot replace a well-trained endoscopist. Thank you for your attention.
Thank you very much.